I'd like to introduce Dr. Tom Gilhooly from Scotland. Welcome, Tom.
Hello, Linda.
Could you tell me when you first heard about LDN?
First I heard of it was a patient came into my surgery in August, 7 years ago, and with her husband, an MS patient, in a wheelchair. Nice lady, had never really asked me for anything and said maybe an antibiotic or two. And she wanted to try it, and I could tell by, just her appearance and that of her husband that they were full of hope that this was going to do something for them. So I didn't really feel as if I wanted to refuse them, but I didn't know anything about it, so I had to take some soundings and phone round and speak to a few people and look into it as much as I could before I went ahead.
So what did you find when you were doing your research?
Well, I found that the advantage I had was having done a lot of addiction medicine. I was comfortable with naltrexone. I think this is one of the big things that holds it back, is that most doctors have never prescribed naltrexone. And so they don't know the drug. So low-dose naltrexone sounds every bit as scary as naltrexone does because they're not aware of how safe the drug is. So I had the advantage of knowing the drug and a bit confused as to why she wanted it, because it's been a very unsuccessful and unpopular drug in addiction because it causes opiate blockade and makes people feel very strange. So I couldn't really understand why she wanted it, but I thought, well, at least it's going to be safe. And I had a long conversation with Bob Lawrence in Wales, and Bob was very convincing that this was a good thing to do and was a safe thing to do, and that there were lots of benefits to it. So I read back about Dr. Bahari and Dr. Zagon, and I thought this looks like something that's going to do no harm, and it may do some good. So that's what that's the basis on which I proceeded.
And what were the results you found with the patients that you prescribed LDN for?
Well, that very first patient, thankfully, had a very marked improvement in her hand tremor in the space of a month, and I was really stunned by that. I couldn't believe it. And of course, it's just as well that happened, because otherwise I might have not prescribed it again. So that was very encouraging, and from there, basically, I started using it in other patients, and it very quickly spiraled, and we've now got 125 patients in my practice on it, not for just MS, because I've only got 4,000 patients on my list, so I've got about 6 MS patients, but we use it for a wide range of immune-related conditions. And I got an update just the other day that it was up to 125, and we've got over 500 people from in a clinic. So it's really become quite a big part of our practice.
And where do you see LDN going?
Well, I think the key thing, as we've discussed many times, is to convince other doctors, and I see from the figures that that is coming on gradually. Research is the thing that convinces other doctors, and I've spent 6 years trying to get a project off the ground. It's very difficult. I haven't so far managed to persuade any neurologists to come on board. We have got through several of the hoops, but we're still progressing that, and I hope I've got a consultant neurologist who's interested now. So that's going forward. I'm also actively looking into a trial in chronic fatigue syndrome, and I've got an appointment to go and see one of the university's departments to discuss that. So I think the way forward has got to be research, and it's not easy to do because this is not a drug that attracts a lot of attention from the drug companies. There's never going to be a profitable payback from it. So we're relying on universities getting interested in individuals who feel that the drug is worthwhile.
So what would you say to doctors who are considering prescribing LDN but are very sceptical about it?
Well, I would say that we have to be honest and say the evidence base is weak, but the evidence base is only weak because there's not been enough studies and enough research done. It's a very safe drug, and very, very few side effects. Got a proven safety record at a much higher dose for a long time, and there's a definite mechanism that we can identify as to why it should work and why it does work. And the fact that we have now got published research across a whole range of different immune-related conditions makes you feel, well, it's certainly one that's worth trying. I think the key thing is to introduce it at low doses and to titrate up slowly, because if you introduce it at a dose of even 3 milligrams, that can be too much for some people. And that was my original advice, and I changed that quite quickly because I realised that some patients couldn't tolerate 3 milligrams. But, over the years we've discovered quite a wide range. There seems to be a big individual variation in the tolerance for the drug. I've got one patient on 0.5 milligram every second day, and she feels much, much better on it than she does off it. So every time she tries to stop it, it makes her feel worse, so she continues to take her 0.5 milligram every second day. And I've got another patient at the other end of the spectrum who's on 25 milligrams a day, and she actually now takes half of her full dose tablet because that makes more sense than using liquid, which is what a normal prescription is. So it's a wide range. I think if people are aware of that, and I had this conversation last night with a GP from down in England who had emailed me, and I just happened to be sitting by the phone, so I phoned them and discussed it with them. And I think when people understand that it's not a miracle cure, it's just a good treatment, and it's a good treatment that, if introduced correctly, there's a very good compliance rate, very low side effect rate.
And what would you say if people said that they didn't think LDN was working and they wanted to stop? How long would you encourage them to try it for before giving up?
I try and keep them on it for quite a long time. I mean, one of the things that we do is cajole people to say, look, until we reach the level where you reach opiate blockade, which is variable, when you get to that point, if you've still not felt any benefit, we now try splitting the dose to see if we can get the doses higher, because the opiate blockade is a nuisance. I mean, that's what the addiction patients feel, and they don't like that all their endorphins, all their opiate receptors are occupied by this drug, which has got no opiate activity at all. And we know that because taking people off LDN, you don't get any withdrawals or any withdrawal symptoms, and you would do if it was having any impact on the opiates. So it just is a pure antagonist that sits in the receptor and has no activity. When all of your opiate receptors are blocked, you feel pretty unwell. So we try and get it up to the level where that happens, and then bring the dose down the next day by 0.5 milligram. If they've reached that point and there's been no improvement in symptoms, and we're generally looking for fatigue as being one of the key indicators that the drug's working. So sometimes people will say, this isn't doing anything for me, but then when you question them, they say, well, actually I'm less tired, and it's maybe been quite a subtle improvement and they haven't noticed it. And it's only when they stop taking it that they realise that actually the drug has been doing something. So we try and encourage people to stay on it as long as possible to try and get an effect, because if they've made the decision to go ahead with it, they usually want to see some improvement, obviously.
Is there anything else that you think would be a benefit to add?
I think the main thing is that we have a very, very good treatment here. There's huge potential for it, and in difficult to treat areas. I mean, this is the key thing, is that we're dealing with immune-related conditions which are very difficult to treat conventionally, except with very toxic drugs with lots of side effects. And the big advantage of LDN is it's oral and it has very few side effects. And looking at, my clinical experience over the years is that this is a very good alternative to steroids, a steroid-sparing drug, really. And that's something that we've been looking for, and the drug companies have been searching for. And if history was different and it hadn't been licensed at the dose that it's been licensed at, then I think this would be an extremely valuable drug. And the very fact that there are a number of patient-led groups and your own charity that are advocating for it is unusual. You don't get that with many drugs. There's not many drugs that people are, actively campaigning and petitioning parliaments about. That tells you something. Patients aren't daft. They do know that there's a benefit to this. I think chronic fatigue syndrome is the area which is so poorly understood. And here we have something that the drug doesn't just treat the condition, it also gives us a very big clue as to the nature of that condition. That it is due to immune overactivity, and modifying the immune system using an immune modulator like low-dose naltrexone could be the key. And that's a very common condition. I mean, probably 4 or 5 times commoner than MS, but very, very poorly treated in general, and lots of patients, have a very tough time even being believed that they're unwell. So that, I think, is a key study. I think we're looking at doing both a study on chronic fatigue and the one on MS, and the MS one's been so long in the incubation that it's beginning to change as we get there. I think we'll probably look at it in a different way, but we're still wanting to go ahead with that, and we've put such a lot of work into it. We don't want to stop now. I think these are key. We're very lucky that some of the American universities have shown an interest in naltrexone, and I think anyone objectively looking at it and seeing that there's animal studies that have been done by Ian Jagon, there's clinical studies, there's double-blind placebo-controlled trials now that show a clinical benefit to this. So consultants, getting consultant rheumatologists and consultant gastroenterologists and consultant neurologists on board is crucial, because these people are listened to, whereas general practitioners quite often they'll say, well, that's fine, but it's a GP, he's not a specialist. Because if we can get some of the specialists interested, then I think that will make a big difference. So we're getting there. We've had one gastroenterologist in Scotland who has applied through the NHS to prescribe this drug, and I've had a couple of chats with him, and he did quite honestly say this would be a fantastic treatment if it works, because it's so cheap and it's so safe and clean, compared to the things that we're actually using. It would be brilliant. So I think a lot of doctors will feel like that, but we just have to get more of them involved, and the more research we can produce, both here and abroad, then the easier it's going to be.
Well, thank you very much for sharing your experience with us, and good luck with all the trials. We hope next year to see the results.